Okay. Okay.
You can go on to the next slide. Perfect. So I'm just going to review what we refer to as the three major dermatoses of pregnancy. And the one thing I will say about dermatology is like, unlike most of the rest of medicine, where we're good at memorizing lists and algorithms, I have found that for dermatology, it's difficult to memorize it. So the solution, I think, is you have to keep reviewing images because it's a very visual science, and it's easy to become unfamiliar with what different conditions look like unless you keep reviewing the imagery. So I really don't think it's inappropriate to keep representing topics like this because it's good to have a refresher in your memory about what these different things look like because the diagnosis is so visual. So a few years back, there was a reclassification of this topic, and you see some of the older names on the right and the new names are on the left. There's actually four conditions. We're not going to talk about cholestasis because it doesn't really actually have a skin manifestation other than just scratching. So we're going to focus on these other three that actually have dermatologic manifestations. So next slide. So the first one is called pemphigoid gestationis. And of the three, it is by far the rarest, occurring in only 1 out of 50,000 pregnancies. And in my 30-year career, maybe I've only seen like 4 cases. So it is very rare. And because of that, it can be challenging to diagnose. This one tends to show up in the 6th to 7th month typically, though it has a very wide range, as you can see, from 9 weeks up through postpartum. It can recur in subsequent pregnancies, unlike other conditions. And when it does recur, it can come back, typically might actually start earlier than the index presentation and often with far more severe symptoms. So it tends to have this sort of circumscribed, confluent, red, itchy rash, often associated with blistering or bullous formation. Next slide. So confluent, blebs, bully, often erosive lesions. And the etiology is thought to be due to circulating antibodies that are directed against the bullous pemphigoid antigen in the basement membrane of the skin. It's thought that perhaps the primary site of autoimmunity is the placenta, as these antibodies also bind to chorionic and amniotic epithelia. The rash is characterized by intensely pruritic, itchy eruptions of red papules, plaques, and vesiculobullous lesions, so blisters, blebs. It typically starts around the umbilicus and then spreads out to the trunk extremities, can involve the palms and the soles of the feet. Interestingly, the face and mucous membranes are spared. And again, the second and third trimesters are the most common time for presentation, rarely may present postpartum. But for patients who have it, postpartum flares are actually very common. We'll often cover them with a dose of steroids immediately after delivery to prevent a flare. Up to 25% of patients can actually have a flare remote from pregnancy when started on oral contraceptives or during a menstrual cycle. So again, just the real sort of tip-off are these bleb formations, bullous lesions, and its location initially starting around the umbilicus. So the way to make the diagnosis other than visually is to perform a skin biopsy. Skin biopsies are actually crazy easy to perform. Anybody who's can inject something local anesthetic and perform a skin biopsy. The key is immunofluorescent staining will be positive for complement and immunoglobulin along the basement membrane. Serum levels of this anti-BP180 antibody actually can also be positive, and those can be followed as markers of disease severity and response, but rarely is that necessary because you can just tell visually that the patient's responding to treatment. This condition actually can be associated with a newborn rash due to passive transfer of the IgG antibodies. Overall, seems like 5% of newborns are affected, and if they are, it will resolve spontaneously in 2 weeks, usually doesn't require treatment. This one actually does have some association with obstetric complications. So there's an increased observed incidence of fetal growth restriction as well as preterm delivery. So this is this would be a severe case, what you might see if a neonate is affected. I will say in the past, there was some concern that this might be associated with an increased risk of stillbirth, but that does not seem to have borne out in more recent studies. It does have an association with autoimmune diseases such as Graves' disease and also vitiligo. So you can start treatment with topical steroids if it's a very mild and very localized rash. But I'll say most patients have this progresses to such a severe case that they almost all require some sort of systemic treatment, such as oral prednisone in fairly high doses. So you initially sort of ramp up with a high dose, and then you'll dial it back to sort of the lowest effective dose to keep the rash under control. As I said, we'll often give stress steroids around the time of delivery and a boost postpartum to prevent a postpartum flare. Continue the treatment for 8 to 10 weeks postpartum as you sort of taper the dose down. You can try oral antihistamines, but they're really kind of a very mild and not terribly effective treatment for the intense itching these patients typically have. So again, just a sort of confluent rash, often with these sort of well-subscribed boundaries to the lesions. Next slide. And again, just to find the blebs, the bullous lesions are sort of like the hallmark. The fact that they don't get oral lesions can help you distinguish this from something like target lesions and erythema multiforme, things of that form. They can, on the skin, they can look very similar, but the absence of the face and oral lesions can help you rule out those as in your differential. So this is just what a skin biopsy would show. In the upper left, you see just the sort of the roof of a bleb, and then with immunofluorescent staining, you see that it light up along the basement membrane. That's the hallmark for this condition. Secondly, we're going to talk about the polymorphic eruption of pregnancy. We still often will refer to this one as PUP, but the name's actually been changed to polymorphic eruption. It has these other rare names, but I find it's either being called polymorphic eruption or PUP. This was actually much more common, seen in up to 1 in 160 to 300 pregnancies. 3/4 of cases will present in primogravid patients. In general, it's considered non-recurrent. There are always exceptions to every rule, but in general, it does not come back in subsequent pregnancies, although up to a fourth of cases are seen in multigravidas. Some have had it in their initial pregnancy, many did not. This one is almost exclusive to the third trimester. So just the timing of the onset of this rash can really help make the diagnosis. Usually around week 36, give or take a few weeks, is when it shows up. The most common week of all is the week right before the due date, week 39. So again, this sort of peri-umbilical distribution. And then the other thing you're going to notice here is very often it will have this linear configuration, seeming to follow sort of body lines. The etiology is actually unknown. Some people think it might be related to skin stretching because it's seen in conditions that stretch the skin more, like twin pregnancies. Some people think it's an immune response to circulating fetal antigens. It's more common when the fetus is male. Usually, again, occurs in nulliparous women late in the third trimester, but may develop in rare cases at any time in pregnancy. There are rare reports of first or second trimester or postpartum presentations. So here again is this tendency for it to form in these body lines, and even in obstetric stretch marks, you'll often see this. Sometimes it's more confluent and patchy, but again, often very linear, like you see here. So the lesions initially tend to show up on the abdomen, periumbilical, often in stria. When a rash shows up in an area of skin trauma, that's called the Kebner phenomenon. And actually, the umbilicus itself is often spared. Then it can spread to the arms, legs, breast, buttocks, back, and in this instance, the face, the palms, and the soles are spared. Pruritus is intense, but excoriation is minimal. I don't quite know how you sort that out, but that's been the observation of the polymorphic eruption. The eruption itself generally lasts 4 to 6 weeks, resolves within 2 weeks of delivery, may last longer in some cases, or in some cases even resolve prior to delivery. The diagnosis here is largely clinical, based upon the history, its time of presentation, and its appearance. A skin biopsy is generally not necessary. If you do one, it's going to show a perivascular lymphocytic infiltrate containing eosinophils. Newborns are unaffected compared to the previous condition we looked at. There's no association with any sort of perinatal morbidity or mortality. Treatment, again, initially topical steroids, systemic steroids for topical failures. You can try antihistamines, but they're kind of not quite potent enough to help in most cases. And then lastly, we'll talk about the atopic eruption of pregnancy, which you can see has previously gone under a lot of different names. This is probably the most common of the three, comprises up to 50% of cases of dermatoses of pregnancy. It's considered a benign, self-limited pruritic disorder of pregnancy. There's often a personal or family history of atopy, such as seasonal rhinitis, asthma, or atopic dermatitis. The etiology is felt to be due to immune changes of pregnancy, such as changes in T helper cell cytokines that lead to eczema. Clinically presents as an eczematous lesion in 2/3 of cases, or prurigo lesions in 1/3 of case, rarely a pruritic folliculitis. This is just sort of an example of what it might look like, kind of widespread, very nondescript, papular, itchy, looks like eczema. These lesions are found on the face, which is different than the other two, neck, breast cleavage, flexor surfaces, which are typical locations for atopic rashes. The diagnosis is usually clinical in a patient with a personal or family history of atopy. Skin biopsies are generally not helpful and are nonspecific. Treatment is moisturizers, so emollient creams and ointments, topical steroids occasionally, oral steroids for severe or resistant cases. Again, you can try antihistamines, but they're rarely effective. Prognosis, no adverse effects on the fetus, usually resolves prior to delivery or within 2 weeks of delivery, may recur in a subsequent pregnancy. So just sort of this general nondescript punctate red itchy rash. Here you can see some where some of the lesions have been scratched and sort of unsurfaced and eroded. Not terribly distinct, very, very bland, generalized rash. So here's a table that just shows some of the more important differences in the clinical characteristics of these three conditions. So you see with the pemphigoid gestationis, it definitely can recur. And as we said, can recur earlier and with more severe symptoms. It is almost always present on the abdomen. Abdomen may start on the abdomen, and it's the one of the three that does have some connection to obstetric complications like growth restriction and preterm labor and a neonatal rash. The polymorphic eruption, by comparison, is overwhelmingly limited to prima-gravid patients. It also almost always starts on the abdomen in a periumbilical location. And then the atopic dermatitis can definitely occur in multiple pregnancies and typically shows up much earlier in pregnancy than the other two, but definitely can be seen in more than one pregnancy. Next slide. So hopefully all your patients will have skin that looks like this, and you won't have to deal with bizarre rashes and itching and the concerns about that. So I think I'll just stop there and see if anybody has any questions.